Welcome to Pediatric Case Review. Today we will be discussing myotonic dystrophy in children, focusing on clinical recognition, diagnosis, and management principles relevant for pediatricians and clinicians in daily practice. A 3-year-old boy presents with delayed motor milestones, difficulty releasing grip after grasping objects, and facial weakness. What is the most likely diagnosis? A. Duchenne muscular dystrophy. B. Myotonic dystrophy. C. Spinal muscular atrophy. D. Congenital myasthenia gravis. The correct answer is B. Myotonic dystrophy. The characteristic combination of myotonia, evidenced by difficulty releasing grip, along with facial weakness and developmental delays, strongly suggests myotonic dystrophy. This condition exists in congenital and childhood onset forms, with varying severity. A newborn presents with hypotonia, weak cry, respiratory distress, and an inverted V-shaped upper lip. The mother reports experiencing muscle stiffness herself. What is the most concerning diagnosis? A. Neonatal sepsis. B. Congenital hypothyroidism. C. Congenital myotonic dystrophy. D. Prader-Willi syndrome. The correct answer is C. Congenital myotonic dystrophy. This severe form typically presents at birth with hypotonia, respiratory insufficiency, and feeding difficulties. The maternal history is crucial. Maternal myotonic dystrophy is present in nearly all cases, often previously undiagnosed. Mortality can reach 25% in the neonatal period. Which clinical feature is least commonly associated with childhood myotonic dystrophy? A. Ptosis and facial weakness. B. Difficulty releasing grip, also known as myotonia. C. Progressive muscle hypertrophy. D. Gastrointestinal dysfunction. The correct answer is C. Progressive muscle hypertrophy. Unlike Duchenne muscular dystrophy, which may initially present with pseudohypertrophy, myotonic dystrophy characteristically causes muscle wasting and weakness. Common features include myotonia, facial weakness, ptosis, and motor delays. This is truly a multi-system disorder affecting the gastrointestinal and cardiac systems as well. A 5-year-old is being evaluated for suspected myotonic dystrophy. Which examination technique best demonstrates the characteristic myotonia? A. Testing deep tendon reflexes. B. Asking the patient to squeeze the examiner's fingers, then release quickly. C. Testing muscle strength against resistance. D. Observing gait pattern. The correct answer is B. Asking the patient to squeeze the examiner's fingers, then release quickly allows direct observation of myotonia, the delayed relaxation after voluntary muscle contraction. This is the pathognomonic finding in myotonic dystrophy. You may also observe percussion myotonia or difficulty opening eyes after forceful closure. Interestingly, myotonia often improves with repeated contractions, known as the warm-up phenomenon. An 8-year-old has been diagnosed with myotonic dystrophy. Which physical finding is most likely to be observed on examination? A. Myopathic facies with temporal wasting. B. Hepatosplenomegaly. C. Joint hypermobility. D. Cerebellar ataxia. The correct answer is A. Myopathic facies with temporal wasting. Children with myotonic dystrophy typically develop a characteristic facial appearance with elongated faces, ptosis, and weak facial muscles, giving a hatchet appearance. Examination also reveals distal muscle weakness, especially in the hands and feet, and often reduced deep tendon reflexes. Skeletal abnormalities like scoliosis may develop over time. Myotonic dystrophy is characterized by which genetic mechanism? A. Deletion in dystrophin gene. B. Point mutation in sodium channel. C. CDG trinucleotide repeat expansion. D. Mitochondrial DNA mutation. The correct answer is C. Myotonic dystrophy type 1 results from an expanded CDG trinucleotide repeat in the DMPK gene on chromosome 19. This causes toxic RNA accumulation that disrupts normal cellular function. The disease shows anticipation, increasing severity and earlier onset in successive generations due to expansion of the repeat during transmission, particularly through maternal lines. A 6-year-old presents with myotonia and facial weakness. What is the most appropriate initial diagnostic test? A. Muscle biopsy. B. Genetic testing for CTG repeat expansion. C. Serum creatine kinase level. D. Electromyography, also known as EMG. The correct answer is B. Genetic testing for CTG repeat expansion. This is the gold standard for diagnosing myotonic dystrophy type 1. While electromyography may show characteristic myotonic discharges and serum creatine kinase may be mildly elevated, genetic testing provides definitive diagnosis. Additionally, the size of the trinucleotide repeat expansion often correlates with disease severity and age of onset. Which finding is inconsistent with the diagnosis of childhood-onset myotonic dystrophy? A. Normal intelligence. B. Markedly elevated creatine kinase, more than 10 times normal. C. Percussion myotonia on physical exam. D. Family history of cataracts in mother. The correct answer is B. Markedly elevated creatine kinase levels exceeding 10 times normal is inconsistent with myotonic dystrophy. In this condition, CK is typically normal or only mildly elevated. Severely elevated CK suggests other muscular dystrophies like Duchenne or Becker. Learning difficulties are common in childhood-onset myotonic dystrophy, and a family history of early cataracts in parents, especially mothers, is a valuable diagnostic clue. A 7-year-old with myotonic dystrophy has troublesome hand myotonia that affects school activities. What is the most appropriate initial management? A. Physical therapy only. B. Trial of mexiletine. C. Corticosteroids. D. Muscle relaxants. The correct answer is B. Trial of mexiletine. This sodium channel blocker can effectively reduce myotonia and improve functional abilities. While physical therapy is an important component of management, it alone may be insufficient for disabling myotonia. Corticosteroids, which are used in some other muscular dystrophies, are not effective for myotonia. All patients require regular cardiac monitoring as conduction defects are common. A 10-year-old has myotonic dystrophy. Which specialist referral is least likely to be needed in their multidisciplinary care? A. Neurologist. B. Cardiologist. C. Nephrologist. D. Pulmonologist. The correct answer is C. Nephrologist. Renal involvement is uncommon in myotonic dystrophy. In contrast, neurologic care is essential for managing muscle symptoms. Cardiac evaluation is critical due to the high risk of conduction abnormalities, and pulmonary assessment is necessary because of the risk of respiratory muscle weakness and sleep-disordered breathing. Multidisciplinary care improves outcomes in this complex disorder. A 9-year-old with myotonic dystrophy requires cardiac monitoring. What is the most important cardiac complication to monitor in this patient? A. Dilated cardiomyopathy. B. Conduction abnormalities. C. Pulmonary hypertension. D. Valvular heart disease. The correct answer is B. Conduction abnormalities. Cardiac conduction defects are the most common and concerning cardiac manifestation of myotonic dystrophy, including first-degree AV block and bundle branch blocks. These abnormalities can progress to complete heart block or ventricular arrhythmias with risk of sudden cardiac death. Annual electrocardiograms are recommended, with consideration of Holter monitoring in symptomatic patients. A 6-year-old with myotonic dystrophy needs dental extraction under sedation. What is the most important perioperative concern? A. Risk of malignant hyperthermia. B. Increased sensitivity to anesthetic agents. C. Prolonged recovery from neuromuscular blockade. D. All of the above. The correct answer is D. All of the above. Children with myotonic dystrophy have increased anesthetic risks, including potential malignant hyperthermia-like reactions, increased sensitivity to sedatives and anesthetics, and prolonged recovery from neuromuscular blocking agents. Respiratory complications are particularly common. Preoperative cardiopulmonary assessment is essential, and procedures should be performed in centers familiar with the condition under the supervision of pediatric anesthesiologists. An 8-year-old with myotonic dystrophy has poor school performance. What is the most likely associated factor? A. Learning disability. B. Vitamin D deficiency. C. Growth hormone deficiency. D. Absence seizures. The correct answer is A. Learning disability. Cognitive impairment is common in childhood-onset myotonic dystrophy, with many children having learning disabilities, attention deficit hyperactivity disorder, or features of autism spectrum disorder. Neuropsychological assessment is recommended to characterize specific deficits. Individualized education plans are often needed to support academic success. This cognitive profile differs from congenital myotonic dystrophy, which typically causes more severe intellectual disability. Which factor is associated with the best prognosis in childhood myotonic dystrophy? A. Symptom onset after age 10 years. B. Absence of cardiac involvement at diagnosis. C. CDG repeat length less than 100. D. Female sex. The correct answer is C. CDG repeat length less than 100. The size of the trinucleotide repeat expansion correlates with disease severity and prognosis. Smaller expansions typically result in later onset and milder manifestations. Later symptom onset is also favorable. Cardiac involvement significantly impacts life expectancy. While myotonic dystrophy is progressive, the rate of progression varies considerably between individuals. Parents of a child with myotonic dystrophy seek genetic counseling. What is the most accurate information regarding inheritance? A. 25% risk of affected offspring if one parent is affected. B. 50% risk of affected offspring if one parent is affected. C. Only transmissible from mothers. D. Sporadic mutations are common. The correct answer is B. Myotonic dystrophy follows an autosomal dominant inheritance pattern with a 50% risk of transmission from an affected parent. While both parents can transmit the condition, maternal transmission carries risk of the severe congenital form. The phenomenon of anticipation means that children may have earlier onset and more severe symptoms than their parents. Genetic counseling and testing should be offered to all family members. In conclusion, myotonic dystrophy in children is a complex multi-system disorder requiring recognition of key features like myotonia, facial weakness, and systemic involvement. Diagnosis is confirmed through genetic testing, and management requires a coordinated multidisciplinary approach. Thank you for watching this pediatric case review presentation. Please follow our channel for more educational content, and feel free to leave questions in the comments section below.